overwhelming amount of information that you can get with prostate cancer, more scores and numbers, and ultimately they kind of are stacked up on your internal scale of whether or not to have a biopsy or have a...
They said that now is the time we're going to put the dye in.
Mm-hmm.
I don't know what that's all about.
It's MRI contrast, so the tissue, cancerous tissue tends to pick up contrast more than non-cancerous tissue. So it lights up and gives the radiologist an indication that tumors have more blood vessels in them. So the contrast preferentially is in the blood vessels. So if you see an area light up and everything else nearby doesn't light up, gives you an idea, hey, there's something abnormal about that tissue.
What about, I've been on hormone therapy for 11 years or so, and I'm kind of coming out towards the end, edges, working the edges in terms of using that as a means. Have you had, in your testing experience, have you had many examples of a tumor that's partially refractive and partially still responsive within the same tumor, and what's your strategy? Would just talk to me about that.
Sure. So when you mean refractive, you mean
you can't use ADT. It's no longer works.
Okay, so it's become castrate resistant to that.
Yes, exactly. That's one of the ways. Yeah.
Yeah. So that's kind of another kind of one of those as speaking to before about the tumor DNA is that the cancer that you have mutates because it's abnormal tissue by definition, and the cancer that you had or were diagnosed with 8-10 years ago, 8-10 years later, it's been exposed to hormone therapy, it's been exposed to different modalities. That tissue, because they have such rapid turnover of the cells, eventually no longer needs hormones, no longer needs testosterone to grow and progress. So, you see these long continuums with patients. I have patients, sound very similar situation, were on hormones for years and remain responsive for years. Some people a decade of response or more. Then there's other patients that are on hormones for 1 year, their PSA drops to 0, and then all of a sudden 1 year later, they're still castrate. They have 0 testosterone. PSA starts climbing up. What that means is there's been some cells within the prostate that have mutated and no longer need testosterone. So then you get into that castrate-resistant phase of disease where you start talking about abiraterone and enzalutamide, other more newer agents that are used in that.
Have you heard about using testosterone in a refractive situation? There's some research I know at Johns Hopkins now where they're actually having some results where the tumor gets disoriented, basically, and they've had some effective, but it's dangerous, especially if you have the kind of situation I was just describing to you, where you have a tumor that's active in both directions, and so is it safe to alternate, like where you address, like what you might want to address the refractive, and let the other go and then come back for it? I mean, someone like me who's like, I'm a vet, right? So I'm just like planning on living forever with this cancer, right? And that's so that's the strategy that I'm presented. One of the strategies I'm presented with right now, and I just want to get everything you got in your head.
Yeah, no, that's definitely one of those. That's a catch-22.
You bet it is.
If you ever hear about one. So
I do.
I don't know of that specific protocol at Johns Hopkins, but I think what they're getting at is
it's research. It's ongoing, and it's. Well, do you know about the research at all?
Not that specific study,
but it's what I'm saying. It's come out. Sure. It's not like in the backyard.
Sure. I think what they're getting at is, and that's I don't know if anyone in the room is familiar with. There's the idea of continuous hormone therapy and then intermittent hormone therapy.
Right. That's
intermittent came about because if you take someone who has a PSA that's detectable, give them hormones for years and years and years, you're basically very similar to bacteria getting a resistance.
Right.
You're presenting that cell with something it can become resistant to. So people have come up with the idea that you give someone 6 to 9 months of hormones, knock their PSA down as low as you can get it, and then let the body naturally, let your testosterone come back, and your PSA may not rise to a concerning level for months, if not years afterward.
Yeah.
And then you potentially don't have the side effects of continuous hormone
That's
therapy.
really intermittent is what, if you can get if my body and the condition can be stable enough to be manipulated in that way,
Right.
then that, I can live with that.
Sure.
You know, because if I have testosterone 3 months out of 6,
Right.
I'm happy.
Right, absolutely, and that's the quality of life component. That's always a huge part of the discussion with prostate cancer. So the quality of life part often in counseling patients takes a lot longer than the simple cancer. The part of the tumor itself. It's hey doc, what does this mean for my sexual and my urinary quality of life?
Right.
And as soon as you throw hormones in it, hey, I can't chop wood anymore, I'm winded going up the stairs, I don't feel like myself.
Right.
Those are all big discussions.
See, I've done that. I went to the testosterone and used that for 3 months, and it was with under my doctor's care, under my oncologist's care, and I'm 73, and so like rebuilding, it's difficult to rebuild when you don't have testosterone, as we all know. You know, and so to have testosterone and use it, I'm just done with that.
Mm-hmm.
And it didn't really work because of that was the question I was asking you, the refractor, the mix.
Right.
You know, was that? But I think I'm going to do it again if I live through this version of it, because it is so vital, and having that strength and having that ability to use my body, because at my age, if I can't use my body at a high level, I deteriorate quickly.
Sure.
And so these are survival skills.
Absolutely, and that's the age-old question whenever you're dealing with patients with cancer, because it's going to be all different, way different spectrum for each patient. You know, are you having a quantity of life or a quality of life discussion?
Yeah.
And that is a very personal discussion based on you and your family and your doctor.
And it gets more stark than that, because it's like you can't live without it, and it's killing you in this other direction. So you have that dichotomy. It's just, and they're both very strong cases. Yeah.
Well, thank you for sharing.
Yeah, thank you for your knowledge.
So the cases that one run through, just kind of operationalize all this, all that kind of long drawn out discussion about genetics and MRI, which I know just usually sets the audience on fire whenever you get into that. So just to kind of show, in a clinical scenario, when would you use these? So let's say you have a 55-year-old gentleman, active surveillance for Gleason 3+3 prostate cancer, had low volume disease,
That's me. That's exactly me.
That's you.
55 and 3+3. Perfect.
Exactly. It's like I've seen a few of these before.
For the past 6 years.
Exactly. So 1 year since his last biopsy, PSA at biopsy was low, 4. His PSA is now 7. So, what are his options? Well, is it wrong for the urologist to offer another biopsy for that change in PSA? No, I don't think so. That would be an option, to have another standard 12-core biopsy. With the advent of MRI, that's a good option for that specific patient as well. Is that now you say, we know you have 1 core of low-risk disease, let's do an MRI on you and see if we really need to put you through another biopsy. Because there's a sepsis risk with biopsy, especially subsequent biopsies, and that's a real problem. So that patient undergoes an MRI and they see a PIRADS 4 lesion. That's biopsied and it comes back with high-risk prostate cancer. So then that patient goes on to definitive therapy. There's the other patients that have the MRI and it shows a PIRADS 1 lesion, or it shows that there's no big concerning areas.
In my case, they didn't show anything.
Didn't show anything, exactly.
And so is that 3 Tesla available over here locally or not? Because when I found out, it was only available in the Los Angeles area. It was not offered over here.
How many years ago was that?
This was 2 years ago.
2 years ago.
It was not available in the Seattle area. There are only like 7 areas in America where they were offering the 3 Tesla test.
Right.
So I had to go to LA to do that.
Right, and NIH and some other places had, they were, offering to have people come out to be part of these studies, kind of, really you were on the bleeding edge of kind of the patients that were benefiting from it. In terms of 3T Tesla, I know that from my experience at Multicare that I believe they have a 1.5 Tesla. I think they have to use the endorectal coil with theirs, but that was a couple years ago. I don't work there and order that test very often. So, but locally, you're only going to see more and more of it come about as this gains steam, because MRIs are here to stay. I think that projecting in the future, I think ultrasound-guided biopsies for elevated PSA is not long for the world. The problem is the pain aspect of it. So, yes, sir.
Is there any value, I haven't heard any mention of a PET scan. Are there any value in prostate cancer?
Sure. So PET scan, and I wrote this one down just because it comes up fairly often. PSMA PET scan, and there's a choline PET scan. Those are markers that they use that adhere to prostate capsular proteins, so kind of the outer edge of the prostate. So it should be prostate specific. So they give you a marker, and then they see where the disease is. It is useful for patients that maybe have a detectable PSA after definitive therapy, and a standard CT scan and a bone scan don't show bony metastasis, don't show lymph nodes. Those tests, some people say, are more sensitive, looking for the metastatic disease to see where it is. Because men, as they kind of go through the prostate cancer spectrum, some people have a detectable PSA, and there's a lag time to when it becomes metastatic, if ever. And these tests, like the PET scans, are kind of looking for, hey, can we see where that little bit of tumor is before the other studies find it? Right now, it's offered at different centers, kind of mirroring almost the way the MRIs was a few years ago. UCSF and other centers offer them because they're on protocol, on study, but they are available. It hasn't quite hit the mainstream acceptance to the level that it would be available at Franciscan or Multicare or something like that. But that's an active part of research. Example case number 2, 68-year-old gentleman, 3 cores of Gleason 3+3, and then he has 1 core of 3+4. So by definition, that 1 core of 3+4 pushes him into the intermediate category. His PSA is 7.7. He says, I have good sexual function and I have good urinary function. I don't want unnecessary treatment to mess that up. So, what could we offer him? I think if you asked someone a few years ago, what would you do with that patient? They would say, hey, they're intermediate risk. They need surgery or radiation. Again, that's not wrong, and everyone has different practice patterns, but that's where some of the genetic testing can tell that gentleman who has 1 core of intermediate risk disease, are you truly intermediate risk? And that you should, that you have high-risk features enough that, hey, you're going to say, okay, I understand I'm high risk. This is my risk of metastasis or dying from this disease, so I will undergo surgery and kind of have my urinary and sexual quality of life potentially disrupted by that to gain a cure, or am I a candidate for surveillance? That's where like a Prolaris or an Oncotype would be useful. So that patient, intermediate risk by the standard definition, if he comes back with a score of 9 or 10 on one of those genetic tests and says you're actually low risk, we all feel better about telling that patient you can be on a surveillance protocol and that we're not going to fall asleep at the wheel while your cancer progresses. And that patient would potentially be able to keep their urinary and sexual quality of life, and we would monitor them still closely, but it kind of helps push them out of that intermediate risk category and maybe into the low risk category where surveillance is possibly an option for them. So I think just in conclusion, then I'll kind of open the floor to any other questions and stuff. Continuing to chirp up here. Prostate cancer really, the big thing is just that it's a very variable disease process. It's different for everybody. What works for one person necessarily won't work for the other person. So you want to have as much knowledge as you can and come up with a personalized plan for you. I don't think these tests I think they're useful in some patients. There is a cost aspect and some other considerations you have to throw in there, but if you're kind of on the edge of one of those two, low and intermediate risk category, or kind of deciding, should I go for definitive therapy or is this something I should do surveillance for, that can be useful in that situation. These tests are based off of the patient's individual tumor rather than just a number, saying I'm a Gleason 4+3, he's a Gleason 4+3. Your tumor may have more high-risk features than his. So it's useful and it's very personalized, and I think that's the way you're going to see medicine go, is be more personalized rather than a one-size-fits-all for everybody.
Question?
Sir?
Agent Orange causes prostate cancer.
There is evidence
That's
that...
what I've been told.
Presumed. It definitely doesn't not create it. We see a fair amount of patients with exposures to Agent Orange in my clinic, and obviously in the VA system, very kind of heavy on patients that have been exposed. There is indications that it points that no one has come up with a definitive test or a genetic screening saying this subtype of prostate cancer is caused by Agent Orange, but the evidence is pretty good that there's a higher risk within men that have been exposed.
Can Agent Orange change your genes, which could cause the cancer?
Correct, yeah.
So if you didn't have normally an attitude of having prostate cancer or breast cancer in the family and stuff like that, all runs in the genes. And if the Agent Orange changes that gene, that could cause either breast cancer or...
Correct. Any of the cancers that we see in the patients with Agent Orange, you have to assume that there's an association there. There are going to be people that have no family history, don't have the other risk factors, and develop prostate cancer mainly from bad luck more than anything. But there is the patients that once you start loading the boat with a chemical that known to cause cancer, that certain people, there's this two-hit hypothesis in cancer that you just need 2 hits on the gene to basically remove the regulation and cause cancer. So for some people, they're born with only one of those cancer regulating areas on their genes. Maybe they inherited just one. Then there's other people that maybe one of those was removed by the toxin, and then now they have a higher risk for
So
cancer.
do we do gene therapy
For prostate cancer?
to change that so you don't get it?
Not to my knowledge. I'm sure that's in the pipeline at some
I know
point.
that's kind of a morbid thing, changing who you are, but...
I mean, like changing the mutations that cause the cancer. I think that you have to have a target for that, and they've used gene therapy. It hasn't come into vogue in urology yet. I think that's something you'll see in the next few decades of people with predisposition to some type of cancer or abnormality. And you can introduce genes into them that will basically cover up that defect, but that's way into the future at this point, unfortunately.
Just the gene, taking a look at the genes, the gene testing, would that help develop a way to take the cancer out easier or a better way?
I think that when you target...
have a better quality of life?
I think targeted therapies against the specific mutations within the cancer cells is, I think, your holy grail of cancer therapy. We're targeting the abnormal cells and leaving the healthy cells alone is where it will go eventually, but as mentioned, these different gene tests, Polaris was 46 genes, Decipher was 22, Oncotype was 17. So if you start adding all those up, and you're talking about hundreds of different targets, so you can imagine what the process is to find out which one. And chances are there won't be just one you can target, because everyone's tumor is different. I think in the future what you'll see is someone's tissue will be sampled, they will run that against known basically gene therapy, and be able to target your specific mutations and know, hey, he's going to respond better to this therapy than someone else, he has these genes. They do that now with some breast cancers and some other solid tumors, but it hasn't come in prostate cancer yet.
So having the biopsy DNA tested, does that have to happen immediately? Or
No.
Is the material always available?
As long as there's enough biopsy material, as in...
So you've got your diagnosis, they did the slide.
if it's on file, they should be able to do it.
That's what I was wondering.
In rare cases, the majority of patients are going to be diagnosed on a transrectal ultrasound biopsy. I've learned with some of my patient base that they cannot use a TERP specimen. If you've had a TERP and they diagnosed your prostate cancer, then where we remove the prostate using the scope for urinary symptoms, if we find cancer there, that tissue can't be used. But core needle biopsies can, presuming that you have more than 1% of one core with the disease. They have to have enough of the tumor on your biopsy to be able to send part of it to the company.
And, yeah, I don't remember them giving me a percentage on that.
They can, it's variable depending on the pathologist and the hospital, whether they require it. But most biopsies, they'll comment on 1% of the core, 5%, or they say 50% of the core. But that's pathologist dependent type of thing. But most people, if you have more than one core of disease, they'll have enough tissue to sample.
Yeah, I just had one.
Just one.
One core of 12.
That's the hardest counseling session, is the patient with every option available to them.
Yeah. Other than it was a 3-4. So
A 3-4. Mm-hmm. And that's always the biggest thing, is that it's what fits one patient doesn't fit the other one, and it's kind of having that knowledge to make the right decision. We just have a lot more options now in terms of diagnosis and even treatment than there were 5-10 years ago. And 10 years from now, everything I said right now will be grossly outdated, I'm sure. So.
Sir, I have a question.
Yes, sir.
So, when they do the staging, Gleason score, is that pretty reliable? Like two pathologists will come with the same conclusion, or there's a lot of gray area in terms of saying this is 3, this is 4?
There is a very big human element in it, because it's what the pathologist assigns. So they do have staging pathology, basically guides to look at the description of the glands. So it can always be a second opinion on the pathology is always an option for patients. If you do get that where they say, hey, you have 5% of Gleason 3+4, it wouldn't be unreasonable to ask for a second pathologist to review the case and see, is this truly 3+4? Is this truly 3+3? Is it an overcall or an undercall? Because obviously that's important for the patient. If you decide to go ahead with a surgery or radiation that you can't undo, that's a big kind
so
of
there's
part of it.
some element of art involved.
Absolutely, yep.
Yeah, that's what I'm wondering.
If they say that there were 2 doctors that looked at it, is that a second opinion?
I would say yes. Often, though, in the wording of it, they will say if it's 2 doctors within the same group, I would say probably not a second opinion. Let me amend what I said. Often, what we do at Madigan and other hospitals is if there's something unclear or it's at all ambiguous, and pathologists will sometimes say, like, cannot assign a Gleason score. Those tissue samples could be sent up to the University of Washington or another large center to have an outside reviewer look at it and come back with a report on that. So that's always an option if there's any ambiguity in the biopsy.
Do you recommend your patients to become part of the research at UW?
Yes. It's always patient dependent based on what kind of stage in the disease process that they are. I have patients that have Gleason 3+3 prostate cancer and have an undetectable PSA and will ask, hey, should I go talk to the University of Washington about a study? There probably isn't a study looking at that population base. The people that the studies are really geared towards are the people with metastatic disease or biochemical recurrence, things like that. But there's always other studies that may be useful. So I'm a huge proponent of reaching out to Fred Hutch or UW or other major centers because urologists and oncologists you may see in the community, it's not that they don't have knowledge, they do, but they're not in an academic center where they have big protocols going, big studies that may benefit patients. And you have the opportunity by being part of the study to not only you benefit, but benefit men with prostate cancer in general. You may be kind of that tip of the spear with a new therapy or MRIs or other things that 5 years from now will be a standard of care. So
yeah, my urologist wasn't big on the MRI.
Mm-hmm. It's a generational thing as well.
And I thought, it's kind of like when I had problems with my back.
Mm-hmm.
They didn't want to give me an MRI either.
Sure.
And I said, no, I want to see what's going on to decide what I want done.
Sure. And yeah, absolutely, and that's as different treatment modalities kind of come in, there's going to be differences in the way I was taught. I was taught on the robot for prostatectomy. I have gray-haired colleagues that thought that was a whole bunch of hooey 5-10 years ago, and now more than 90% of prostatectomies in the country are done with the robots. So there's it all kind of, you do run the risk of being a dinosaur if you don't kind of, accept that things change. So,
well, and then if you
but it doesn't replace the biopsy certainly, but it gives you more information.
If you talk to somebody that had the robot 14 years ago, they don't get the outcomes that you get today.
Exactly, it's coming to its own and matured and kind of changed greatly. So it's just riding those waves and picking up where it's headed next, because a lot has changed. When I started my training 8 years ago, 9 years ago now, we didn't have anything really more than hormone therapy and docetaxel for advanced prostate cancer. Now you have enzalutamide, radium, abiraterone, now you have apalutamide, you have all these other therapies that no one knew about. And that's within 8 years is really not that long. So what's it going to be 8 years from now? Maybe completely